Picture this. Your wife is in labor. Complications arise, and you have 30 seconds to decide. Call 911 or trust in God's plan. For millions of Americans, this isn't hypothetical. Two sister communities, identical DNA, opposite life or death medical choices. The decision that splits families forever. The identical beginning. These two communities share everything. Same Swiss Anabaptist ancestors who fled religious persecution in the 1600s. Same boat journeys to Pennsylvania's farmlands. Same core beliefs about adult baptism, pacifism, and simple living. Walk through Lancaster County today and you'll see identical horse-drawn buggies, plain clothing, and rejection of modern conveniences. Yet when medical crisis strikes, one community races to hospitals while the other turns away doctors entirely. The split that created this medical divide traces back to a single heated argument in 1693. The Great Division of 1693. Jacob Amann believed the church had grown too lenient. Sinners deserved strict shunning, complete social isolation until they repented. Hans Reist argued for gentler restoration, showing mercy to the fallen. Their theological debate raged across European Anabaptist communities, fracturing families and friendships. Amann's followers became the Amish, embracing rigid discipline and separation from the world. Reist's supporters evolved into Mennonites, maintaining faith while engaging with society. This 330-year-old argument about how to handle human weakness would determine whether future generations lived or died based on medical choices. Medical philosophy split. The Amish developed Gelassenheit, complete submission to God's will, especially in sickness and death. If God intended illness, medical intervention showed lack of faith. Historical trauma reinforced this belief. Traveling doctors in the 1700s and 1800s often exploited these isolated communities, performing dangerous experiments and charging exorbitant fees for useless treatments. Trust in outside medical authorities shattered. Mennonites interpreted the same experiences differently, seeing medicine as God's gift to humanity, a tool for serving others. Two communities, identical persecution, opposite conclusions about healing and divine will. Community mutual aid system. The Amish reject health insurance as gambling against God's will. Instead, they operate sophisticated mutual aid networks spanning multiple states. When medical emergencies arise, communities pool resources through alms, voluntary contributions that can reach hundreds of thousands of dollars. The system works through district bishops who coordinate fundraising across Amish settlements. Families facing medical bills never pay alone, but the community decides which treatments deserve funding and which represent unnecessary interference with divine plans. Traditional healing practices. Amish healing relies on centuries-old European folk medicine passed down through oral tradition. Community healers, typically older women, use herbal remedies, reflexology, and spiritual counseling. Popular treatments include willow bark for pain, echinacea for infections, and elaborate herbal combinations for chronic conditions. These practices aren't primitive superstition, but sophisticated systems developed over generations of isolation from conventional medicine. Knowledge transfers through apprenticeships, with master healers training successors in secret formulations and diagnostic techniques. Birth and emergency protocols. 95% of Amish births occur at home with lay midwives who learn through experience rather than formal medical training. Emergency protocols exist but require bishop approval for hospital transport. Life-threatening situations create community dilemmas where religious conviction clashes with immediate medical need. Some families accept modern intervention when death seems certain, while others maintain faith regardless of consequences. These decisions often split extended families and create lasting theological debates within communities. Theological medical foundation. Mennonites developed radically different theology around healing. They interpret Jesus' healing ministry as a mandate for medical service, viewing doctors and nurses as instruments of divine compassion. Early Mennonite settlements in Pennsylvania produced the first trained physicians in many rural areas. These medical pioneers saw no conflict between faith and science, believing God revealed healing knowledge through human discovery and education. This theological foundation created generations of Mennonite medical professionals who combined spiritual care with advanced medical treatment. Medical mission development. Mennonite medical missions began in the 1890s with hospitals in India and Africa. Today, Mennonite health organizations operate medical facilities across 6 continents, training local healthcare workers and providing care in underserved regions. These missions reinforce the community's commitment to medical intervention as Christian service. Young Mennonites often pursue medical careers specifically to serve in mission hospitals, creating a cultural expectation that healing and evangelism work together seamlessly. Scientific integration. Unlike their Amish cousins, Mennonites embrace medical technology and pharmaceutical advances. Mennonite hospitals pioneered integration of spiritual care with cutting-edge medical treatment. Many Mennonite communities boast higher than average numbers of doctors, nurses, and medical researchers per capita. They participate fully in medical research, clinical trials, and organ donation programs. This scientific engagement stems from theological conviction that understanding God's creation through medicine honors divine intelligence and serves human suffering. Birth and mortality statistics. The numbers reveal stark differences in health outcomes. Amish infant mortality rates reach 7.9 deaths per 1,000 births, nearly double the national average of 5.8. Mennonite communities report infant mortality of 4.2 per 1,000 births, significantly below national levels. These differences reflect prenatal care access, birth complication management, and newborn medical intervention acceptance. Amish mothers receive minimal prenatal screening, while Mennonite mothers utilize comprehensive medical monitoring throughout pregnancy. When birth complications arise, response time and intervention acceptance often determine survival outcome. Prevention and vaccination rates. Vaccination creates the widest health gap between communities. Amish vaccination rates hover around 68%, while Mennonite rates exceed 96%. During disease outbreaks, these differences become life-threatening. The 2014 Ohio measles outbreak infected 383 Amish individuals across 9 counties, while neighboring Mennonite communities reported 0 cases. Whooping, cough, mumps, and other preventable diseases circulate regularly through Amish populations but rarely affect vaccinated Mennonite children. Health outcome analysis. Life expectancy data shows Mennonites living an average of 3.2 years longer than their Amish counterparts. Cancer survival rates differ dramatically due to early detection practices. Mennonites utilize regular screening for breast, colon, and cervical cancers, catching diseases in treatable stages. Amish cancer detection often occurs only after symptoms appear, resulting in advanced stage diagnoses with poor prognosis. Emergency medical response times also affect outcomes, with Amish reluctance to call ambulances contributing to preventable deaths. Financial system comparison. The economic reality of medical choices creates vastly different financial burdens. Amish mutual aid covers catastrophic expenses but relies on community willingness to fund treatments. A single cancer case can cost an Amish district over $200,000. Straining resources and forcing difficult decisions about treatment continuation. Home births cost approximately $3,000 compared to $15,000 hospital deliveries, making economic sense for uncomplicated pregnancies. However, emergency cesarean sections can cost $50,000 when complications arise during home births, creating financial disasters that mutual aid struggles to cover. Mennonite families typically carry comprehensive health insurance through employers or religious organization group plans. This insurance security allows for preventive care, early intervention, and aggressive treatment of serious conditions without community financial stress. The predictable premium structure enables family medical planning impossible under mutual aid systems that depend on community generosity and competing medical needs. Employment and economic impact. Mennonite communities benefit economically from medical career concentration. Healthcare professionals earn above-average incomes, supporting local economies and funding community projects. Mennonite hospitals employ thousands of community members, creating economic stability and career opportunities for multiple generations. These medical institutions often anchor rural economies, bringing patients and their families to spend money in local businesses. Amish communities lose potential medical professionals to education restrictions. Bright young people who might become doctors or nurses instead pursue farming, carpentry, or small business ownership. This brain drain reduces community earning potential and perpetuates dependence on outside medical professionals who don't understand Amish culture or values. Insurance and long-term planning. Health insurance conflicts with Amish religious principles about depending on worldly institutions rather than divine providence. They reject Medicare, Medicaid, and private insurance as unnecessary entanglements with government and commercial systems. This rejection creates legal complications when emergency medical treatment occurs without consent or payment arrangements. Long-term care presents growing challenges as Amish populations age. Traditional family care systems struggle with dementia, cancer, and other conditions, requiring specialized medical knowledge. Some families secretly obtain medical insurance while publicly maintaining religious opposition, creating internal community conflicts about authenticity and faith. Crisis decision-making. When medical emergencies strike, Amish families face impossible choices between religious conviction and immediate survival needs. The decision-making process involves family consultation, bishop guidance, and often heated community debate, while precious minutes tick away. Heart attacks, strokes, and traumatic injuries create time-sensitive scenarios where religious deliberation can mean the difference between life and death. Ambulance service calls from Amish properties occur at rates 60% below surrounding populations, not because emergencies happen less frequently, but because families choose prayer and traditional remedies over emergency medical intervention. When calls do occur, they often represent life-threatening situations where family members have exhausted religious alternatives and face imminent death. Mennonite communities show emergency medical utilization rates exceeding national averages by 15%, reflecting their proactive approach to medical crisis management. They train community members in CPR, first aid, and emergency response, viewing medical preparedness as responsible stewardship of life rather than lack of faith. Medical intervention acceptance. Surgical intervention acceptance reveals the deepest philosophical differences between communities. Amish surgical rates for non-emergency procedures remain 40% below national averages, even when procedures could prevent future complications or death. Heart surgeries, cancer operations, and organ transplants require extensive community consultation and often result in family divisions when some members support intervention while others oppose it. Blood transfusion policies vary by district, with some Amish communities accepting transfusions during life-threatening emergencies, while others refuse regardless of circumstances. Organ donation remains controversial, with most Amish viewing body integrity after death as religiously significant. Legal and community integration. Legal complications arise when Amish medical refusal conflicts with state laws requiring emergency medical treatment. Child welfare authorities sometimes intervene when parents refuse medical care for minors, creating complex legal battles between religious freedom and child protection. Emergency medical technicians receive specialized training for interacting with Amish families, learning to respect religious concerns while providing life-saving care. Medical emergency documentation presents challenges when families refuse to sign consent forms or provide medical histories. Hospitals develop specialized protocols for treating Amish patients without standard legal protections. Legal and regulatory challenges. Government health mandates increasingly conflict with Amish religious practices. COVID-19 vaccination requirements for employment, school attendance, and public building access created unprecedented legal challenges for communities seeking religious exemptions. Court battles over mandatory childhood immunizations have escalated, with some Amish families facing criminal charges for medical neglect when children suffer from preventable diseases. The legal system struggles to balance religious freedom with public health protection. Recent cases involve Amish children dying from treatable conditions, while parents claim religious exemption from medical intervention. These cases create legal precedents affecting religious medical freedom nationwide and force courts to define limits on parental religious authority over children's medical care. Technology integration pressures mount as telemedicine, electronic health records, and digital medical systems become standard healthcare requirements. Amish rejection of modern technology creates barriers to accessing even basic medical services that increasingly require digital interfaces.